Good afternoon. My name is Hans Loyda. I'm the Director of Clinical Development and Education at Roche Diagnostics, and I'm a member of the Medical Affairs Department. Good afternoon, everybody, and today I'm here to talk to you about the universal definition of MI and how this universal definition of MI relates to troponin. The subtitle is Clearing the Confusion. And the reason why I'm saying this one is looking at the customer base who are using troponins in the real world, in their clinical practice. There is still, although it has been now around for a couple of years, still a lot of questions, still a lot of uncertainties, et cetera, et cetera. And so we saw the value for this educational event. My disclosures is, again, as I said, I'm an employee of Roche Diagnostics. I'm a member of the Medical Affairs Department, and the data here presented in this presentation is purely educational and is supposed or is built on scientific evidence-based data in compliance with FDA guidelines. The program, as briefly described, is intended to review the recent release of the third definition of MI. The new definition of MI has been around for a couple of years, and we just recently had the release of the third universal definition of MI with some updates. It aims to familiarize clinicians and laboratorians of the implications for clinical practice, and we will focus on an understanding of the use of troponins in clinical practice. Briefly, the objectives of this presentation is to describe key changes in the recent released universal definition of MI, review the implications of an elevated troponin, examine the clinical setting where a troponin level or to measure a troponin level is recommended, analyze the prognostic implication of troponin elevations, review non-ischemic conditions which can result in an elevated troponin, and finally discuss the future clinical role for troponin measurements and give a brief outlook of what might be coming. Now, briefly talking about the area of confusion here and now. It's again some details around the definition of MI. The definition of MI has become very complex. But also with its complexity, much more appropriate to the different options of clinical settings in clinical practice. Very important question is how to interpret the results. A troponin used to be many years ago when it was a positive troponin, it was an indicator for myocardial infarction, not today anymore. It is definitely still a very specific indicator for myocardial necrosis or myocardial injury, but not any longer only is it caused by a myocardial infarction. This is caused by or is the result of the evolving nature of troponin assays. They have become much more precise. We can today measure concentrations we could not in the past. The thresholds over time have evolved, and still many people in the field, in clinical practice, are using everything from the 99th percentile, which is the recommendation of the universal definition of MI, but a good portion of clinicians are still using the WHO cutoff and then anything in between. And last but not least, it's important to understand how a troponin should be ordered and what an appropriate ordering of troponin will result in versus an inappropriate. Although the intentions can be good, but it may lead to unnecessary testing. A brief historical overview about the defining myocardial infarction. Way back in 1959, the WHO definition was developed, where we looked initially at clinical symptoms and changes, and myocardial necrosis markers were kind of secondary criteria. Many years later, we started to use CK-MB, and it became the standard, the gold standard, and was used for the definition of MI to define cardiac injury. Later, with the release of troponins, the first troponin T from Boehringer Mannheim at this time, and troponin I from Date Behring. They became approved in the time frame of 1994 to 1995, and they started entering the clinical practice field. Then in 2000, we started redefining the way we are looking at myocardial infarction, and the troponin became a centerpiece in this definition. And then in 2007, the Global Task Force further redefined the conditions for myocardial infarctions and emphasized different conditions which might lead to myocardial infarction. And then back in 2012, as mentioned before, we finally got the third definition of myocardial infarction. Now, briefly, what is the backbone of the third definition of MI? It identifies pathological characteristics, but all the other more classical framework is carried forward, and I will talk about what I mean with this. It clearly endorses troponin now as the preferred biomarker for the specific category of myocardial infarction, which means here the troponin from a standard of gold standard, troponin has replaced CKMB, at least as the guidelines are concerned or as this consensus document is concerned. The universal definition of MI emphasizes that we have to see a rise in troponins. We have to see a pattern, a changing pattern. It requires a rise or fall above the 99th percentile. And while we are watching a patient, observing a patient, at least one level out of serial measurements should be above the 99th percentile. And then again, in relation of a rise and a fall. And the 99th percentile is also a very important term now, which has changed over the last couple of years. As the assays have become much more precise, today we can measure with sensitive assays troponin in normal patients. And troponin is no longer the marker for a myocardial infarction, as I indicated before, but might be, according to a lot of data being published, an indicator for underlying cardiovascular disease. Over time, as patients eventually accumulate damage, troponin levels slowly rise, and we are getting to something we call chronic elevations. But I will talk about this in a little bit. Further, the universal definition of MI has also looked into other things, or into the framework, ischemia and necrosis. They have to be present in order to justify calling the condition of the patient an MI. What is important is that we have those two components, ischemia, which is basically diagnosed through clinical symptoms, EKG changes, and so forth. We can have some imaging evidence for it. But what is important here really, ischemia, signs and symptoms of ischemia are a clinical diagnosis where troponin is not necessarily helpful. Troponins come into play when we are talking about necrosis, when we are talking about dying myocytes. Here, when both conditions, the clinical condition of ischemia and necrosis come together, we are talking about an acute myocardial infarction. Beside this framework, the universal definition of MI has further specified the areas of sudden cardiac death. They have specified troponin elevations or myocardial infarction after PCI or CABG, and are emphasizing some pathological findings. In the most recent the definition of MI, the key points is here what is the threshold for post-PCI MIs, and the numbers moved up from 3 times the 99th percentile to 5 times for PCI, and for CABG from 5 times the 99th percentile to 10 times the 99th percentile. And I would like to emphasize here very clearly that these are consensus thresholds where I would say experts are still discussing if there are high enough, and there are some discussions that there might be even higher. So we need to keep this in mind. Now, moving forward, I would like to switch over the consideration I'm presenting here and refer to the expert consensus document as published by a group of experts led by Dr. Nubi in 2012. I find this publication also very helpful and insightful because it gives us a nice structure how to look at positive troponins as symbolized here in this graphic. One possibility, for example, is we are looking at ischemic, or we are looking at troponin elevation in an ischemic environment, and I'm now trying to put an arrow up, which I can't right now, so I will not play with this further. We have on the left side in a light reddish color the ischemic events. On the right side, we have the non-ischemic causes of troponin elevations. And ultimately, down at the bottom, we have another box of analytical considerations we have to think through as we are looking at a troponin elevation in general. So allow me to first then move to the ischemic part. Again, all starts with a troponin, and this troponin now is presenting itself in an ischemic environment. Then we are talking that we have the classical definition of myocardial infarction. But with the universal definition of MI, we are now differentiating between two types of myocardial infarction. One is the classical type in the setting of what we call acute coronary syndrome. This is the classical type of the STEMI, the non-STEMI, and we have then the condition of unstable angina under acute coronary syndrome, where clearly the atherosclerotic underlying disease is causing the problem. We have the ruptured plaque causing the disruption of blood flow or partial disruption of blood flow. We have the typical signs and symptoms of ischemia and eventually necrosis. So this is the type 1 MI, the ischemic myocardial infarction. From this, we are differentiating now the type 2 on the left side, the non-ACS myocardial infarction, where we are dealing more with the supply-demand issue, where the supply either is not satisfying the demand for oxygen in the heart muscle, or where we can have a drop in blood pressure or anemia or arrhythmia, all conditions which are leading to a condition within the heart that the oxygen supply is not sufficient to catch up with the demand, and this is now causing a necrosis. But what it has to be said very clearly, if we have an MI of a type 2 MI, we wouldn't see blockage. We wouldn't see the rupture of a plug because we have here a different mechanism in place. Now, the universal definition of MI specifies also and includes also categories for sudden cardiac death. But then there are the procedure-related types. Type 4 related to a myocardial infarction secondary to PCI, and the type 5 CABG-related. And I made a reference before about the different levels for PCI, now 5 times above, or 5 times the 99th percentile, and CABG 10 times the 99th percentile as critical thresholds. And as I was referring before to confusion, education is here very important, that we keep our clinicians up to date about these evolving recommendations, these evolving changes, where again education is most critical for people to keep up with what is happening. Now again, we are coming back to ACS and want to focus a little bit on, for a little while, on this to clarify this. ACS again describes clinical signs and symptoms that evolve from a pathological process which then leads to rupturing, leads to a disruption in blood flow. We have the clinical signs and symptoms. They degree on the impact of the myocardium impacted is has an impact on the degree of symptoms we are seeing. The severity of ischemia or has ultimately an effect on the myocardial necrosis. And those terms, this term of acute coronary syndrome again includes unstable angina and the MI. The MI part is covered in the universal definition of MI, and here are the typical terms of STEMI and non-STEMI, as most of you are familiar with. When we are looking at troponin results in this context, we have here the classical release criteria of troponin, the pink or the kind of purple color and the blue color for troponin I and T. There is a quick rise of the troponin results, and then over a period from 7 to 14 days, slowly the troponins disappearing after myocardial infarction. But we have a very large window where we do see clearly troponin elevations. For then many years, we have the discussions about other markers, the role of CK, CKMB, myoglobin, and so forth. And as I said before, the universal definition of MI clearly emphasizes that the troponin is the gold standard. And as these tests, the troponin tests are becoming more sensitive, and we have in other parts of the world high sensitivity tests. Other markers like myoglobin, who used to be the early markers, are losing of importance and are not as critical anymore. As the troponin tests are becoming more sensitive, we are seeing a quicker rise in the troponin, and the troponin in general peak in a time frame of 24 hours within the time frame of the event. Now some brief mentioning of the different types of MIs, the type 2 especially. Up in the first picture we have the type 1 where the ruptured plaque is disrupting the blood flow. But as type 2 is more demand and supply question, we can have spasms, we can have imbalance in blood supply. These are can cause myocardial infarctions. In general, myocardial infarctions of type 2 are milder, not as severe as type 1, definitely not as severe as the STEMIs with complete blockage, but in general are milder. And clearly, when we are looking into the coronary arteries, we don't see blockage, which we do see in type 1 MI. So again, we had touched on all these components, positive troponins in all these conditions. From here, we are now moving to the right part of the graphic, and I will talk briefly about non-ischemic causes of troponin elevations and the condition we have in these kind of cases. Now again, looking at the kinetics, the kinetic patterns of the release, and compare acute versus chronic. In the acute setting, as I demonstrated before, we have this typical rise and fall after myocardial infarction. We have high levels for several days, while for a typical chronic elevation like heart failure, we do have measurable troponins eventually present in the patient samples. But as we are looking at them over time, we do not see dramatic changes. Now here I want to emphasize another point which I should have mentioned a little earlier. The universal definition of MI requires a rise and fall, but unfortunately we are not yet at that level that there is a recommendation of what rise and fall is required in order to represent myocardial infarction. Experts are discussing 20%, 50%. There is a lot of discussions about what those can be, but again, the guidelines are not yet at the point where they are defining definitions of deltas. Coming back to chronic elevations, when they stay the same, the print on the right side on the blue part of the graph was very small, but we have conditions here like chronic kidney disease, heart failure, pulmonary embolism, chemotherapy-associated cardiotoxicity, sepsis. All those can be conditions, and these are only a few of a long list of reasons which can cause chronic elevations. Now, as we are looking at the prognostic importance of those elevations, here we have depicted 6 different conditions, starting on the upper left side, heart failure, then sepsis, acute stroke, pulmonary edema, non-cardiac critical patients, or post-operative vascular surgery. The point of this slide is that whenever there is a troponin elevation, whenever there is a higher troponin level, it is bad news for the patient. And whatever graph you're looking here at is when a troponin is elevated compared to those patients with the same condition who do not have similar elevations, the prognosis for this patient is worse. So troponin elevations in chronic conditions, although not rising or falling, but staying relatively stable, do have prognostic implications, and the patient does worse as we are looking forward. The other example is renal disease. And here also detectable troponins are very common. And what is here also depicted some troponin I's and the troponin T. Again, the message here is really when we are looking at no elevation or low elevations versus higher elevations with the red arrow, patients do have a worse prognosis, so they are clinically relevant. And moving to the last part, which are some analytical considerations. Here, what is important are things like heterophil antibodies, human anti-animal antibodies, rheumatoid factors, or fibrin interferences. These are all coming either from the patient or are related to the sample. And not always does a troponin elevation mean a chronic underlying disease, but we have also to look at and ask ourselves the question, do we have those components, those analytical components causing those interferences? There are solutions out there, blocking agents, or the package inserts from the manufacturers have to be specific about the specific interferences so that laboratories are aware if they are seeing results which clinically cannot be explained, that they are looking for reasons what this can mean on the analytical side. Now, besides those interfering factors, we also need to consider something else, which is the variability between troponin results. Although we are referring to troponin I and troponin T, each troponin of the different troponin is different, meaning an I is not an I. So as eventually we see a patient being transferred from a different facility into our facility, we might see a troponin result coming with them in their electronic medical records or the records they're having with them. Comparing this then to the in-house troponin, there can be a difference in results, and this is due to eventually the different methods being used, the different manufacturers, the different versions of a manufacturer. This is depicted here in this table with a lot of detail. But the cause for this differences is really that we have different antibodies binding to different epitopes, so they are measuring everything slightly different. And as a result, as we are looking at the 99th percentile, that is that point of our reference population where that level of troponin describes that 99% of normal patients would be below this point. As you can look at those numbers, there are a lot of different numbers representing that clinically the differences are between those troponins, which you can clearly then see with the 99 differences in 99th percentile values, that the values cannot be necessarily directly compared. Now, applying the 99th percentile and putting this in context of where have we come from. On this graph, it's a nice graph which tries to explain this. I was talking about with the increased sensitivity of assays, we can measure troponin values in more and more normal patients, which are the normal population is represented in green on the left side of the graph. While when in the past, when we looked at the Hore definition, we measured troponin at relatively high levels. As assays became more sensitive, it took several years until we finally reached the 99th percentile. The 99th percentile is now represented here as the red bar at the upper end of the normal population. Now, as those assays over time became more sensitive, finally the sensitivity is enough so that we can now measure down to the 99th percentile and below. The reason I'm emphasizing this one here is really that the world hasn't changed in regards of troponin. Very often we are getting the feedback from clinicians is you do measure too many troponins. They are unreal. They are not they're representing the clinical presentation of the patient. The bad news is they are real. They can cause confusions, and it is important whenever we are measuring a troponin, and we are sure that this is not an analytical artifact, that we do explore what cause is causing this rise, so that we get an understanding of what the underlying conditions is if it is not an MI. So if we do deal with chronic elevations, that we do understand where those are coming from, that because it has important implication for the patient. Now, one last important point with the universal definition of MI, and this is the interpretation, or this is the reference to the precision. And what I mean here is, as we have still all different types of troponin tests on the market, some of them are very sensitive, some others are less sensitive. I need to emphasize that in the United States, we have at this point not a high sensitivity assay approved yet. There are some of them are available in other parts of the world, but there is not a commercial assay with the designation of high sensitivity. But we have many contemporary assays. Some of them have the title of more sensitive, sensitive, ultra, and so forth. But they are all, as the experts are calling them, contemporary assays. And the different assays can have different precision, and the universal definition also reflects on this. They're saying the assay should have at least a CV of less than 20%, then it is acceptable. Ideal, optimal would be that they measure at the 99th percentile with a CV of less than 10%. But there is this wiggle room what the guidelines are offering. Ideal, again, less than 10%, but clinically acceptable still up to 20% of CV. Now, one final remark to the interpretation of the troponin results. And I talked about very briefly in the introduction about the appropriate and inappropriate testing. As we are looking at when we should order troponin, and the expert paper makes this clear, we really need to differentiate between, and it's a little small print at the bottom, we need to really differentiate, do we have a high-risk patient or do we have a low-risk patient? If we have a high-risk patient, which could be that patient who has typical angina symptoms or EKG changes or a history of coronary artery disease, if I have a high-risk patient, my pretest probability is very high. And with a high pretest probability, I do have, with a positive troponin then, a high positive predictive value. And the higher the positive predictive value for this troponin is, the less unnecessary workups do I need to do. If I have a high-risk patient and the troponin is negative, there is a relatively high negative predictive value, a higher certainty. Now, I'm not saying that when a high-risk patient comes into the emergency room and has a troponin, negative troponin, we're done. Now, then is when the patient needs to stay, and we need to watch the patient because there could be a late or a later release of troponins over time. But the level of risk, the pretest likelihood for myocardial infarction is important for the interpretation of troponin levels, because if the risk is low and the pretest probability can drop as low as below 10%, the meaning of a positive troponin is completely different. We would have a low positive predictive value, meaning the ratio of a true positive who have the disease, who have a myocardial infarction, compared to those who don't, is more unfavorable. Or when a low-risk patient comes in with a negative troponin, what does this really mean, and what diagnostic implication does it have down the road? So pretest probability, am I ordering a troponin for a high-risk patient versus for a low-risk patient, needs to be put in context of my assessment of the patient. So the major challenge here in clinical practice is often the inappropriate ordering. And what I'm meaning here is more when we are having protocols in place where every chest pain patient, for example, might get a troponin. And we do have institutions where this is the case. Under these conditions, is really the quality or the clinical quality of the information provided by a troponin can really suffer. So an important thing we need to keep in mind, and an important thing we need to educate people about. So as a result, we have really a call to action for the laboratory to reduce this confusion. It is really important to facilitate the understanding of troponins for the medical staff. It is important to look and inform about the performance characteristics. It's important to really clarify the thresholds being used, and it's important for people to understand, for the people who are dealing with the patients, understand that we can have ischemic and non-ischemic elevations, that we can have acute elevations which have the tendency to change. There's a rise and fall, and the chronic elevations which stay relatively stable over a period of time. But when we are establishing the diagnosis of MI, of course, we are not only diagnosing a condition. The next question immediately becomes, what are we going to do with the patient? And I will talk now about those clinical implications. Dr. Skirica, a couple of years ago, proposed a scheme like this. And he looked at what is the role of a marker in general in the diagnosis, where the goal is really to identify a disease and differentiate from non-diseased patients. Here, the troponin in this context answers the question, or in context of ACS, answers the questions, do I have type 1 or type 2 MI in this patient? But then it goes beyond. A troponin elevation in an ACS patient has also its implication for risk, for what is the prognosis of this patient. And we have learned over the years that an increased troponin is correlated to the short-term and long-term prognosis of the patient. We have implications for 30 days in regards of risk of death and MI. Those 30-day risks are very important to consider as we are looking at rehospitalization rates, which are a critical metrics for clinical performance in today's environment. So identifying those patients who are at elevated risk here is very important that we capture them all. But then we need to also look at the clinical implications. How do we treat those patients? Identifying patients at a high risk is not the only thing, but then also it is the question of what are we going to do with the patient. Now, this is an old concept. This is a traditional concept. I shouldn't say old. It's a traditional concept. And my point here, why I'm bringing this one up, it is important to understand that as we are discussing the universal definition of MI, as we are discussing the 99th percentile as a critical threshold, as the lowest threshold we have had in the many years of troponins, that this threshold has not been evaluated as it relates to risk stratification, but more importantly to the clinical implications, to the questions of what are we doing with the patients. This is emphasized in the most recent management guideline for non-STEMIs and unstable angina, where the guidelines do make the important statement that the implications of the universal definition of MI with the use of the 99th percentile have not been explored fully in regards of implications of what we should do with the patients. Should we intensify all the options we have? Should we send all the patients into the cath labs? Those implications have been explored with previous versions of troponins with higher thresholds. So that is an important concept. Now, allow me a brief time to look at risk stratification in ACS patients. And I have here in this next slide, risk stratification for ACS patients, 30 days risk of death and MI in Gustav 4. The point I'm trying to make here is when I'm looking at the risk of death or MI, and I'm looking at the different thresholds of, in this case, troponin T, what I see here is really that we have non-detectable troponins on the very left, and then troponin elevations on the three right groups of bars. When we have no troponin elevations in this setting, we have a baseline risk for death and a baseline risk for reinfarction. I right now see questions are coming in, and which reminds me also, you can ask questions and type them into your system, but I will wait until later towards the end until I will start responding to those questions. So I have to ask you for a little bit of patience. Baseline risk on the very left side with undetectable troponin Ts. As we are now looking in this range, in this second group, detectable troponin levels 0.01 to 0.03, which is a 10% CV of the troponin T currently commercially available in the market. We do have a group of patients in this range between detectable and 10% who do have an increased risk now for death and who do have an increased risk for reinfarction. As the threshold moves further up, between 0.03 and 0.1, which is the WHO cutoff, again, risk increases. And as then the thresholds are clearly within the WHO, this traditional cutoff range, there is another increase in risk for death. The risk for MI is not further increasing because those patients have been treated, and those treatments, you can see the impact of treatment. The message here is, as we are moving stepwise through the different possibilities of thresholds, any release builds incremental or provides incremental risk for the patients already within 30 days. And then what are the clinical implications? And they have been examined by the Tactics TIMI 18 trial many years ago. The key point of this trial was they looked at patients who had either non-STEMI or unstable angina, and they compared two therapeutic options, invasive therapy and non-invasive therapy. And what was interesting in this trial, although it was an overall positive trial where invasive therapy had a better impact, showed better outcomes in patient, the benefit of really the invasive therapy was clearly limited to those patients with detectable troponins. Here in this case with troponin, any troponin elevations above the detectable level of 0.01 nanogram per milliliter. This benefit was not observed in the troponin negative patients. So here we see already a possibility if we have an ACS patient, a clear ACS patient, and they do have a troponin T elevation, this patient benefits from the cath lab and is observing or has a benefit of 50% reduction in death and MI at the 30-day time frame. Not so in the troponin negative setting. So that is another area where we do have really this connection between here an ACS patient who has a measurable troponin. They do have a benefit from a more aggressive therapy, even from the most aggressive one which we have with the invasive therapy, sending the patient to the cath lab with the intent to treat in case blockage is found. But I want to also clearly emphasize another point, which is, again, we are not treating a patient based on their troponin, but we are treating the patient in context of the clinical setting. And that the question of the therapeutic options are really in clinical context. So it is the global risk assessment which is important rather than just a single marker in general. Just to clarify that I avoid misunderstandings that we are treating lab numbers. Those numbers have to be interpreted in clinical context. But now, as I mentioned before, as we are looking at the universal definition of MI and the use of the 99th percentile, we still require more data to really understand the implications on do we have incremental risk? Very likely we do have based on some first publications, but what should we do then in this setting in regards of how should we treat those patients? Again, with the universal definition of MI, for example, we are finding those patients with troponin elevations who have a type 2 myocardial infarction, and a lot of those type 2 myocardial infarctions should not go to the cath lab, should not be treated. Type 2 MIs are very likely more frequent in women, and we do know that not that all women needed to be sent to the cath lab. So again, we need to be aware as we are dealing with the 99th percentile, we need to really look for data to help us further to decide what the role of troponin is as we are intensifying therapy. And let me also emphasize this here very clearly. Especially since I'm a presenter from Roche Diagnostic, I need to make those statements, which can be different from many experts who are practicing medicine in the field. A practicing physician, our experts, our KOLs can make different recommendations based on their clinical experience. As a Roche representative, I need to focus on what data is available. And my reference about the clinical implications is that if there is data, it is very limited what we have available, so we need to be careful about those areas. So what are the challenges for future cardiac assays? And those have been described by Dr. Apple very nicely. He mentions here, for example, that with high sensitivity assays, we do get more precision at lower concentration. The measuring range is going very low to now 1 nanogram per liter or 1 picogram per milliliter. So this is, we are seeing numbers, the measuring range or the reported units are changing. For high sensitivity assays, we will not see the 0.0 some number, but we will see picograms. But what we do need to keep in mind is we also don't have FDA-approved high sensitivity assays available in the market, because we are still trying to understand what is the difference between the ROC optimized cutoff as we are starting to use the 99th percentile. We need to really make sure that there is enough accuracy at the 99th percentile, and we have to clearly find the understanding so that the clinical understanding in clinical practice, so that we minimize really false positives, findings, or misinterpretations of troponin in clinical setting. There is a proposal from Dr. Apple about how do we define sensitivity, and that has been published in his scorecard, which is gaining more and more acceptance among experts. In his scorecard, he clearly looks at precision at the 99th percentile. Here again, the guideline acceptable, less than 10% CV, clinically usable, if the precision is greater than 10% but less than 20, and not acceptable when it's greater than 20%. Now, as we are looking at now sensitivity here in context of how many of the normal reference population do have a detectable troponin with a given assay, we have contemporary assays which detect within the normal population less than 50% of them with a detectable troponin. If we are then moving to high sensitivity assays, this portion of how many patients, how many of normal of the reference population do have measurable troponins. With the most sensitive tests, we can have up to 95% of the normal population having measurable troponins. Now, translating this into clinical practice, we clearly see also here the potential for confusion, because all those patients, now we can imagine that we have a lot of our patients coming into the emergency room who have a problem, have now a measurable troponin, and there is this hesitation of what this means. It has prognostic implications long-term, but for the interpretation whether or not this patient has an MI, again, education is here required. Reminding again us to this graph here, where the sensitivity now goes down so far that we clearly can differentiate between diseased and non-diseased, but the troponin levels can be measured in the normal range. If we are measuring up to 50%, we are talking contemporary assays. If we are measuring up to almost up to 95%, we are talking the high sensitivity assays. Now from here, I will make some closing remarks and really emphasize again that the standards for clinical laboratory operations is really important. What we call them, what do we call the different troponins, that we are specific, what we really mean, how do we understand the designation of high sensitivity assays. What is also very important is, as we are looking at the reference population, is how are we determining the 99th percentile? Are we determining it by looking at patients with no underlying cardiovascular disease? Or are we looking at patients, hospitalized patients, for example, who do not have an MI? The 99th percentile would be a completely different. There is not a final conclusion about what those criteria should be to determine the appropriate 99th percentile, although there is a clear tendency to look at not really at patients with underlying cardiovascular disease here, but the final word has not really been said. We might see a cutoff gender specific. We might see an impact of aging. We need to clearly differentiate acceptable imprecision, absolute versus relative changes. What is more important needs to be considered. There are some publications out there for the more sensitive tests, differentiating clearly between acute and chronic elevations, having analytical and biological variability in mind, and so forth. So all those criteria need to be considered as we are moving into the future. So again, then troponins are no longer specific only for MI. The troponin elevation has an implication of what is suspected with the patient. If I have a high-risk patient, there is a high susceptibility for MI. If I have a low-risk patient, a different story. Again, that refers to the pretest probability. A troponin is also recommended and can be used in CK patients. Again, here we are looking at especially a change in troponins over time. And then we have really to anticipate, as we are encountering more non-ischemic conditions which can have troponin elevations, routine troponin testing is not recommended for those kind of conditions. So those are a couple of important considerations. And then finally, we really need to reflect that troponin elevations outside ACS are not uncommon. They still mean cardiac or can mean cardiac or myocyte injury, and we have those conditions being listed. And as we are looking at troponin elevations in non-ACS environment, they are prognostic, they are not false positives, and they have implications for the future disease progression of this patient. Now, in conclusion, we need to remember that troponin is only one piece of the puzzle, and we clearly have to interpret those troponin results in clinical context. And with those words, I now will go to questions and answers. And if you again have more questions, please feel free to type them in. My first question I have here, and it's a longer one. I have to see if I can expand it. Just with me. Can I get help? I see. Okay. Sorry, I was looking at the wrong part. The question is, can you please expand in your second point of risk stratification, referring independent association as opposed to patients with disease? Again, let me eventually step back what I was referring to. As we have ACS patients, in ACS patients, we clearly have each incremental troponin elevations is representing for incremental risk, short-term risk of MI and death. This is different from the chronic elevation. The chronic elevation doesn't have this change over time, but still, if I do have a chronic elevation, and in one patient I have a chronic elevation which is lower than in the second patient, the patient who has the higher chronic elevation is at an increased risk for a future event, is at an increased risk for future death, which means also here the level of troponin elevation is giving me information, but they are definitely long-term, and they are always meaning a higher troponin elevation gives higher risk than if there is a lower elevation. I hope that this clears it up. Another question is, my second question is there any need to continue CKMB testing in routine community hospital laboratory for the use of detecting reinfarction? Interesting question. When we are looking at really, I should say there is a preference for some people to still use CKMB, especially for reinfarction. But troponin does do a good job, and there are publications, especially from Mayo, Dr. Sanger published around this, where there is really no need for CKMB. The guidelines are also emphasizing that troponin is the gold standard, and I'm aware of many institutions who eliminated CKMB from their test they are ordering, from tests they are offering, making it more difficult for physicians to order this test, which are all an indication that if you really look at reducing the complexity in what you are dealing with, that the relevance of CKMB is today not there anymore, even in case of reinfarction. We still would have time for more questions, so I will give it a few moments. So as I don't see any more questions in, I would like to thank the audience for your participation. Really appreciate this on a Friday afternoon, or depending on where you are on the globe. I have seen that we have some international dial-ins where it is now at night. Appreciate your time, appreciate the opportunity for presenting to you. Thank you very much for your time, and have a great weekend. Thank you very much.